Welcome back for the second part of our EKG interpretation. So we just went through analyzing EKGs in the first part. We want to use a roadmap, an algorithm to do this. If you don't, you can tend to kind of jump around and it makes it a little harder to figure things out. So we're going to be doing it kind of a step-by-step. First off, we're going to look at sinus rhythm. And, sinus rhythm, and, sometimes we call it normal sinus rhythm. This is a good thing. It reflects normal electrical activity in the heart. We know that, or we think that then the impulse originated in the SA node and travels through the heart. And so one of the things you're going to see is, even though this is a sinus rhythm, there's some funky things in there that we'll be talking about. So how are you going to go about figuring out what this is? We're going to go through the steps. This is the outline of the steps that we just talked about. Look at rhythm, rate. So this is our algorithm, plus some extra information in here. So first off, we want to determine whether the rhythm is regular or irregular. And so what you're going to need to do here is you're going to look at either the P waves or the QRSs, and you need to look beat to beat to see whether they're regular or irregular. Sometimes it can be a little tricky. So what we used to use, and they're still kicking around, are calipers. And so you see here what they've done is they've marked from beat to beat, and then what they'll do is take the calipers and keep dropping them to make sure that it marches all out. Now what you guys can do, and can't really show you here unfortunately, is you can take a piece of paper, and I would take something bigger than this, and line it up so that you can mark. You'll see what they did. They marked across from this beat to this beat, and then what they're going to do is take that as a ruler, so to speak, and move it to check this to this to this, that it marches all the way through. And if we do that, we see that this rhythm is regular. Okay, so we are regular here. Next thing we want to do is calculate rate. And so remember, we're going to do this as a 6-second strip. And when you look at the strip, do you see that I've got a mark right here? Okay, another mark here. So from here to here is 3 seconds. And then I'm going to find the next mark. Okay, this is from here to here is another 3 seconds. So I've got from here down to here, from here to here. Okay, so I'm going to start counting complexes. All right, 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9 times 10, that gives me a heart rate of 90. Okay, so a rate of 90. So I'm regular so far, and I have a rate of 90. Now I'm going to look for my P waves. And before I go pointing them out, I want you to look at the rhythm strip and find the P waves. So hopefully you are looking at this little bump right here. This is a P wave. This is a P wave. This is a P wave. Here's a P wave. Now you'll notice that I've got these 2 strips going here. What's that all about? Well, these are what are called 2 different leads. And so remember, the recording that we see depends on how the electricity, whether it's moving be towards or away from a positive electrode. This top lead, this top view is called lead 2. And with lead 2, I have a negative electrode up on my right shoulder, a ground on my left shoulder, and then the positive electrode is down on my my left anterior side of the chest. So it's a little bit lower down in the chest. And so the vectors, the electrical vectors coming from the heart are moving towards that positive electrode. And so that's why these complexes are upright. When I look at this particular view, this is called a V-lead. And so with the V-lead, the positive electrode is typically it's along about the fourth intercostal space, right along the sternal border, the left sternal border. And so the forces from the atria should be moving towards the positive electrode. So the P wave, which is right here, should be upright, and it's not. The forces then from the ventricle should be moving away from the positive, or towards the positive, away from the positive electrode. And so this complex, the QRS complex, should be all negative. It shouldn't be biphasic. And then, of course, we know our T wave should be upright and rounded, which is not. So even though this is a sinus rhythm, it has some issues. So back to P wave. The easiest P wave to see is probably going to be this one. So these are P waves. And remember, we're going to identify that there's a P wave in front of every QRS, and that they all look about the same, and they're upright and rounded in this particular lead. So that's good. Next thing I'm going to measure is the PR interval. And so remember, that has to start at the beginning of the P wave to the beginning of the QRS. Now, it's going to drive your eyes bonkers if you try to sit and count baby boxes. It's really, really hard to do. So one of the things you can do is take that scrap of paper that you had and lay it right underneath here, okay? And then draw a line on the paper. Here's the beginning of my P wave. Here's the beginning of my QRS. And then take that piece of paper and line it up down here where you can see all the little baby boxes. And when I do that, and I'm just eyeballing this, folks, it looks like my PR interval is going to be just a little bit over 4 baby boxes, okay? So from here to here is just a little over 4 baby boxes, which would mean it's about a 0.16. Remember, a normal PR interval should be between 0.12 and 0.20. So far, so good. Next thing I'm going to look at is my QRS complex. And so this is my QRS complex. Now notice, this doesn't have a Q wave. Q wave should have been a downward deflection. All I've got is an RS wave. I'm still calling this a QRS. So my QRS complexes, I've identified them, and I do need to make sure they all look about the same, which they do. Okay, they don't change in shape. It's not like I've got this complex here and then, something different there. I'm going to do that measurement of the QRS. And so I need to, let's see, this one. I'm going to start at the beginning of the QRS, which is right here, to the end of the QRS, which is right here. And it's 2 baby boxes. And so my QRS complex measures 0.08. Next thing I need to look at, ratio. Ratio means that I have 1 P wave for every QRS, and so my ratio is appropriate. It's 1 to 1. The next thing I look at is ST segment, and so remember, I've got my QRS, and then this right here is my ST segment, so it's between the S wave and the T wave, and you'll notice something about the ST segment. It is depressed. So let's go back to where I can find the isoelectric line. It looks like my isoelectric line is up here, and when I draw across, I notice that I'm a baby box worth of depression, because it should be up here. So I do have some ST segment depression in my lead 2. What can I do with that? Well, I'm not going to run screaming down the hall. I'm going to pull out the chart and I'm going to check the labs and see if electrolytes look okay. I'm going to look at lead placement. I'm going to look, could there be some ischemia or something going on? Is this a change? But just looking at this strip, I'm not going to jump up and down too much about it. Now, I would note that I do seem to have some ST segment depression. It looks like it's at least a baby box that's at least 1 millimeter in depth. T wave. And so my T wave, notice it's a little bit on the pointy side. Not too bad, but it's not really rounded. So although I'm not happy with the shape of my T wave, it is what it is. So I can note that it's a little bit on the peaked side, but I do have T waves, and they're consistent all the way through. Notice on this lead, so here's my upside down P wave. This is my QRS, and it's kind of this biphasic QRS. So the QRS starts right here and ends right here. This is my ST segment right here. And then this is my inverted T wave. Okay. So I want to do my QT interval. And so that's going to be from the beginning of the QRS right here to the end of the T wave. And like I say, don't try to count baby boxes because it'll drive you bonkers. Take your little piece of paper and line it up and put a line on the paper where the QRS begins, and then another line where the T wave ends. Or excuse me, we're measuring QRS. Where the QRS begins, well, we already measured the QRS. So, did we? So, if we didn't measure the QRS, we did, yeah, we did that. Is 0.08. We did ST. Sorry, I'm losing track of things. All right, beginning of the QRS to the end of the T wave. Okay. And when I draw that little line on that, it looks like on this I'm just a little bit over, somewhere around 0.4 seconds. Or 0, yeah. 0.20, 0.24, or excuse me, 0.20, 0.4 seconds. So it looks like I'm at two big boxes on that. Maybe a little bit over, no, a little bit short of 2 big boxes. So it's probably okay. So I'm going to say my QRS, or excuse me, my QT interval looks okay. All right, so back to, sorry, it's late at night, I'm starting to wander. So settings, so this is, you know, in general, it's a sinus rhythm, and so that piece of it is considered normal. I do have some abnormalities potentially in terms of the T wave and the ST, and this rhythm really doesn't look the way it should. It could be because of the way the electrode, or the way the energy is passing through the heart. It could also be placement of electrodes, so I would have to investigate that. So, you know, you do want to assess your patient. You know, get blood pressure. We want to look at the hemodynamics. This is electrical. Do we actually have good cardiac output? Or is the skin warm and dry? Is capillary refill good? Are they mentating? Do we have a decent blood pressure? You know, pulses. So you've got to assess all that. Remember, treat the patient, not the monitor. All right, looking at this next rhythm, it's labeled sinus bradycardia, but how do I know that? So first thing I'm going to do is look at rhythm. Is it regular or irregular? And so remember I said the easiest way to do it would be from R to R. And so get your piece of paper again and put it right there and draw a mark where on this R wave and this R wave, and then take the paper and march it through to make sure that this interval is regular all the way through. And it is. So we do have a regular rhythm. Rate. I have a grid mark here, a grid mark here, and one here. So from here to here is 6 seconds. So I'm counting complexes within that 6 seconds. 1, 2, 3, 4, 5. So I multiply times 10 and I get an estimate of 50. So I have a bradycardic rate. Now I'm going to look at my P waves. I'm going to look for P waves. And so once again, you have 2 different leads. You have your lead 2 and your V lead. Now, what do I mean by leads? We looked at this before, but one of the things you noticed is this is the same electrical complex as this, but they look different. It's kind of like if I was standing in front of you and I was looking at you face on, you look different when I look at you face on as when I look at you from the side. You're still you, but it depends on the angle that I'm viewing you from. These are different angles. Same beat, different angle, okay? And there's reasons to use different leads. For example, lead 2 is a great lead for looking at atrial issues. And so if I have a patient that has atrial fibrillation or atrial flutter, I want to look at lead 2. But if I'm concerned about ischemia, heart attack sorts of things, ventricular issues, then lead 2 is not the best. The V leads are the best because it's going to tell me more about the ventricles. So that's why we oftentimes see more than one lead used when we're, examining the heart. All right, so we've determined that the rhythm is regular, that the rate is in the 50s. So we have a bradycardic rate. We have a P wave. We find P waves. And so remember, this bump is my P wave. Now you'll notice the P wave here almost looks a little biphasic because it's kind of this bump and coming back up. This is the easiest one to see, so use this. P wave, P wave. Remember, I want to make sure that there's a P wave in front of every single QRS and that they look about the same, which they do. Then I'm going to measure my PR interval, and you can take your strip, a little piece of paper and line it up, or look at here. This P wave starts right on one of these dark lines, and if I look to see, so remember PR intervals from the beginning of the P wave to the beginning of the QRS, which is right here, I'm actually covering 4 baby boxes, and so my PR interval is 0.16 seconds, and that's within normal limits. All right, I'm going to examine my QRS complexes, and so that's these, and I have kind of a biphasic QRS complex, so these are my complexes, and they all look about the same. Same here. Here's my QRS complexes in the V lead, and they look about the same. I'm going to measure the QRS complex for duration, and so I'm going to start right here. So here's, right here. Oh, did I do my, I did my PR interval. So for the beginning of the QRS to the end of the QRS, notice how it comes back, the little tail comes back, and we come right back here. So that's the end of it. And it covers 2 baby boxes. And so I've got a QRS complex that measures, or QRS interval, of 0.08. Ratio, I have a P for every QRS. ST segment. So remember, the ST segment is this stretch of time from the end of the QRS to the beginning of the T wave. Now I got a funky little T wave here. I can't even see it on the V lead, which is not good. Not that it's not good patient-wise. It's not good in terms of documentation. Somebody should have gone back on here and made sure that the leads were placed appropriately so we could actually see everything that we needed to see. So here's my T wave, and you'll notice it's not upright and rounded, it's inverted. But here's my ST segment, which does go back to baseline. So if I draw a baseline, I'm back at baseline there. So my ST segment is isoelectric. T wave is abnormal in that it's inverted, and I'm going to do a QT interval. And so I have to measure from the beginning of the QRS, which is right there, to the end of the T wave, which looks like it's right about there. Okay, see if I can find one that lines up a little bit better. Beginning of, okay, here we go. This one, because I don't have a piece of paper, I can't take a piece of paper up on the screen for you. This QRS starts at one of the dark lines is what I'm looking at. And so here's my beginning of my QT interval. So from here to here, so I've got a big box, so this is 0.4 to here, and then 2 baby boxes. So my QT interval is about 0.46 or 0.48. Wait, 2 big boxes, I'm sorry, is 0.40 plus 2 baby boxes, about a 0.44. Now this is bradycardic, so at a rate of 50s it may need to be corrected, so the QT interval may actually be a little longer than it should be. It depends, but we don't need to worry about that. For our purposes, it's still less than 0.44 seconds, and so we're good. Okay. So setting on this, sinus bradycardia, don't jump up and down about it just as sinus bradycardia. You have to look at your patient. There are many people who have a resting heart rate that is in the 50s or 40s, especially when we're looking at people that have well-conditioned hearts. We'll also see heart rate drop down under, when people sleep at night, deeper stages of sleep. You might notice that if you're working on night shift. If you get into a really deep relaxed state, your heart rate will slow down. And, so this can be a normal finding. But there are medications and there are some circumstances where not so much. We know that there's some medications that can slow the heart rate. For example, DIG, beta blockers, calcium channel blockers. Conditions, elevated intracranial pressure is listed. Now, this is something that goes along with a condition called Cushing's triad, and it's not good. So if the patient has a head injury and their heart rate drops and their respiratory pattern changes, and their pupils are dilated, then you need to really be worried about that. So, that'd be a bad circumstance. Heart attacks, sometimes we'll see Brady, sometimes we'll see tachy. Vagal stimulation. So, when we stimulate the vagus nerve, that causes parasympathetic response and the heart rate will drop. What kinds of things stimulate the vagus nerve? Well, hold your breath, cough, bear down, you're pushing out a poop or you're pushing out a baby, you're having a lot of pain, things like that can cause the heart rate to drop. So it can be vagal stimulation. Hypothyroidism, hypothermia, so there are some things that will cause this. So intervention, now you'll notice, what does it always start with? Assess, 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 assess your patient. So you want to make sure, remember that you're gathering vital signs, that you're checking perfusion. We want to look at skin color, temperature, capillary refill. We want to look at level of consciousness and figure out whether they're stable or unstable. Are they symptomatic or not? Now, if they're asymptomatic, and remember this is ACLS algorithm, then we're going to continue to monitor and observe. But if they're symptomatic, the first thing we're going to do is administer atropine. Now, atropine works by increasing conduction through the AV node, and so that should increase the heart rate and also improve blood pressure and cardiac output and things like that. So the dosage on the atropine is 0.5 milligrams. We can give it every 3 to 5 minutes to a max of 3 milligrams. And like I say, you always have to monitor. You administer something, you do something, and you've got to monitor to see if it worked. So you're going to check vital signs and all that other stuff. Now, according to ACLS algorithm, if atropine is not effective, the next thing we should look at if this patient was symptomatic, would be transcutaneous pacing, TCP, to increase the heart rate and thereby improve cardiac output. If TCP is not available or there's going to be a delay, then we look at medications, and it would be dopamine or epinephrine, not as a push, but as a drip. And so we would titrate our dopamine or epi drip to get the blood pressure to at least 90 systolic and, reduce or get rid of the, signs and symptoms that are making them, unstable. So that's sinus bradycardia. So sinus tachycardia, it says it's sinus tachy, but why do we know that? So we're going to go back through our algorithm again. First off, is the rhythm regular, irregular? So again, take your paper and, line it up here. Put a little mark where there's, put a little mark on these two QRSs, and then move the paper through and make sure that the interval between the QRSs is about the same all the way through. And it is. And so we can say that the rhythm is regular. Now we're going to calculate rate. So I have, here's a mark, here's a mark, here's a mark. So from here to here is 6 seconds. So I'm not going to count this complex. I'm going to count this one as my first one, okay, because this is the line. All right, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Whoops, 11. tried to go further. So my heart rate is approximately 110. So I have a tachycardic rate. All right, now I'm looking for my P waves, and so I'm not going to point to them. I'm going to give you a second to get up there and look at the strip and circle the P waves. Easiest lead to find the P waves on this strip is the lead 2 again. And you'll notice there's a little bit of a kind of squishiness here, some kind of extra stuff. That's just artifact. Remember, people move and breathe and things like that, so ignore that. This is a P wave right here. P wave, okay. P wave, P wave. So I have P waves, and it appears that I have a P wave in front of every QRS, so I'm pretty happy with that. And they all look about the same. Now, where it's kind of wonky, squishy looking over here, that's your artifact. That's your patient moving. Okay, it's not that there's a problem with the P waves. Next thing I'm going to do is my PR interval. And so I want to measure from the beginning of the P wave, okay, right there, to the end, or to the beginning of the QRS. And so beginning of the P wave to the beginning of the QRS, that covers 4 baby boxes. And so my PR interval is 0.16 seconds, okay? And that's within normal limits. Next thing I'm going to do is look at all my QRS complexes, and I'm happy they're there, and they all look about the same. I don't see a big change in morphology. They look about the same. I'm going to measure my QRS complex, and so I'm going to take this one right here. I like this one. And so remember, I start from the beginning of the QRS complex, and so I put my straight line here. This is right where it begins. And then I follow it till it comes back down to baseline, and that's right at this point. And so from the beginning of the QRS to the end of the QRS is 2 baby boxes, and that means my QRS is 0.08. Okay, that's within normal limits. On the ratio, once again, I have 1 P wave for every QRS. Next thing I'm going to look at is the ST segment. And so let's get over here where I don't have a bunch of artifact. Let me see. Okay, this is still a little bumpy, so if I kind of draw my ST segment, there are some spots. See, I see some wonkiness here, which I think is probably movement and not actually ST segment depression, because when I see something that's cleaner, yeah, I might have a little bit of ST segment depression here. So what are you seeing as a problem with this strip? Because of the movement, the patient movement and things like that, it's kind of hard to see things. I might have a little bit of ST segment depression. See how that looks there? And it looks a little bit consistent, but it's kind of all over the place. So I'd want to get a new strip and look at it. So ST segment, possible ST segment depression. Once again, not enough to really get upset about. I don't know that this is a change. I would want to look maybe at the chart and check out electrolytes and things like that. I'm looking at my T wave now, and my T wave is here. And hard to see, this is movement. It's upright. It's not very roundy. Now what I want to do then is find the T wave that's easiest to see when I do my QT interval. And so let's see. This one looks pretty neat because I can see my P wave, my QRS, little ST segment depression. Here's my T wave. And so I'm going to measure my QT interval from the beginning of the QRS to the end of the T wave. Okay, you do that too. Mark it on your paper, beginning of the QRS to the end of the T wave. The nice thing about marking it on the paper is that you can then take that paper down to where you can look and see the baby boxes a little bit easier. So I'm 1 baby box short of 2 big boxes, if that makes sense. So if the duration for the QT interval had been 2 big boxes, that would have been 0.40, but I'm 1 baby box short. So my QT interval is 0.36, which is within my normal range right now. Now remember, this is tachycardia, but still we're just going to say it's within normal range. So when we look at setting on this, sinus tachycardia can be a normal response to certain things. So for example, if you exercise, if you run up and down the stairs, jog around the block or whatever, then you need more oxygenated blood flow to your muscles, and so your heart rate will pick up. Not only heart rate, but your contraction. And that's a normal physiologic response. But you always have to look at somebody that's laying in the hospital that has sinus tachycardia, because why would they be laying in the bed with a fast heart rate? Because it can be a compensatory response to things such as hypovolemia, hypovolemia, anemia. If I don't have a lot of oxygen carrying capacity on my red cells because I'm anemic, then my heart's going to have to work faster or work harder and pick up the heart rate in order to bring oxygenated flow to tissue. Heart failure is another example of a compensatory response, hypotension, hypoxia, and then it can be a response to things like pulmonary embolus, where I have a VQ mismatch and I'm going to try to pick up the heart rate. Cardiac tamponade. Things like pains, anxiety, hyperthyroidism, and stimulants, and that includes drugs, alcohol, caffeine, and nicotine, can increase the heart rate. So assess your patient. When you see tachycardia in your hospitalized patient, think about what the cause could be. don't jump to the, oh, gee, you're just nervous and anxious. Think, what would be the worst thing that could be happening to you? Are you bleeding somewhere that we don't see yet? Are you having a heart attack? Could you be volume overloaded? So make sure you figure out what the problem is. So assess your patient. Maintain the airway, breathing, circulation. Figure out the cause and fix it. And that'll fix tachycardia. We don't give any specific drugs to fix tachycardia. We figure out the underlying cause and we fix that. And the tachycardia fixes itself. So there's a couple things I threw in that are kind of add-ons because you see them frequently, and this isn't something that you'll need to know for testing, but when you're out there working, you might see this, and this particular ectopy might be something that you guys have experienced. You may have felt it, maybe not. Premature atrial contractions, or PACs. With PACs, there is an irritable area in the atria that fires off before the sinus node could, and so it produces beats that are early. And so when we're looking at this rhythm strip, remember the first thing we're going to do is look to see whether it's regular or irregular. And so if I were to take my paper and draw a mark from here to here and use that as my ruler, one of the things I notice right away is, bada bing, I have an early beat. And so then I go along and I'm just fine right from here to here, looks great. And then, oops, I've got another early beat. And then I go back to just kind of regular again. So it's irregular, but specifically I have two early beats. This one right here and this one right here. So PACs are ectopy, not rhythm. So we'll go back to identifying the ectopy, but let's look at the underlying rhythm. If you ignore these and then just focus on this other stuff, the underlying rhythm is regular, okay? Rate, do I have grid marks? I did a bad job chopping this off. So I'm going to do another way to calculate rate. Let's see. Well, I can't. The rate of the regular rhythm, about 75 beats a minute. And so I'm just giving you an approximation. You could go back to the previous strip and take your piece of paper and make yourself a 6-second ruler and measure this out. But it's about 75 beats a minute is our underlying rate. We're not looking at these early beats. On the underlying rhythm, I do have a P wave. Okay, and I've got a P wave in front of every QRS, and except for this early beat. So that's good. Because I've got a P wave in front of every QRS, I can measure my PR interval. P wave, beginning of P wave to the beginning of the QRS. PR interval on this is about 0.16, 4 baby boxes, so that's normal. QRS complexes are there. They all look about the same. I can measure my QRS complex. Let's find one that's good to measure. Aha, here. This starts on a dark line. So here's the beginning of the QRS complex, and here's the end right there. And so I'm going here's baby box, just a little, like 2.5 baby boxes. So it's about a 0.10. ST segment. So here's my isoelectric line. I'm going to start that right there. And my ST segment is isoelectric. Okay, ST segment is isoelectric. Ooh, whoopsie doodle. Do you notice something? ST segment on this early beat is depressed. Get back here. ST segment is isoelectric, isoelectric, isoelectric. And once again, on the early beat, the ST segment is depressed. Well, we'll come back to those. So in the underlying rhythm, my ST segment is isoelectric. T wave in the underlying rhythm is upright and rounded. Okay, here's my T waves. They look nice. Now, looking past the early beat, it looks a little funky, but we'll come back to that. All right, so T wave looks fine on the underlying, and I'm going to do my QT interval from the beginning of the QRS to, I won't use that one because I've got an early beat there. Aha, beginning of the QRS to the end of the T wave is 2 big boxes, so my QT interval is 0.40 seconds. So what's my underlying rhythm? It's regular, it's in the 70s, I've got P waves, they all look about the same, okay? My underlying rhythm is a sinus rhythm. All right, now I'm going to go back to these early beats because I've got to identify those. So when I look at the early beats, the QRSs look about the same. Got a little ST segment depression there, got a little funky look at T wave, but I'm looking, where's my P wave? Notice something interesting. This is the P wave from the beat before, okay? So this would be P wave, this is QRS, and there should be a T wave here. But this early beat came in, an early beat came in, and you'll notice that the T wave here doesn't look the same as the T wave here. Could it be that this T wave also has a P wave on top of it? Probably. So there's an irritable area in the atria fired off. So we get a squishy little P wave because it wasn't exactly coming from the sinus node. And it landed on the top of the T wave, and because it's atrial, it doesn't hurt the T wave. But I got my little P wave here, and I've got my QRS, the conduction, the impulse traveled the same pathways, and my T wave, but because it was early, this particular beat, remember ST segment depression can indicate ischemia, little tiny bit of ischemia here. With this early beat. I don't have as much cardiac output on this beat. This is actually an unusual finding with PACs, which is one of the reasons I hung on to this strip. Most of the time when we see PACs, we just see a baseline on the ST segment. So what do I have here? I have sinus rhythm, heart rate in the 70s with PACs, okay? All right, setting on PACs, and as I said, this is a common ectopy. I would bet almost any amount of money all of you guys have had PACs at one time or another. It can be associated with coronary and valvular heart disease. Digitoxicity, by the way, is associated with any dysrhythmia known to man. Hyperthyroidism, elevated catecholamine levels, your patient's in pain, things like that. We'll see it with respiratory issues such as acute respiratory failure, COPD, also fatigue, anxiety, electrolyte issues, ischemia, well, you can see the list, and then stimulants such as alcohol, nicotine, and caffeine. Intervention is usually none. You may notice that there's a pulse deficit with PACs, meaning that when you've listened to lub-dub, you got a rate of 75, but when you take the pulse, this early beat, because we don't have good ventricular filling, doesn't perfuse very well, and so you got your radial pulse is a little slower than your apical pulse, and that's our pulse deficit. So you may pick up on something like that. Really, we don't give anything specific to fix this. We just try to figure out what's going on with the patient, that this is happening. Why is the heart irritable? We look at their med list, we look at, our electrolytes, things like that, and we fix those things. The only time, just to let you know, sometimes patients will have increased frequency of PACs before they go into either atrial fibrillation or atrial flutter or something called paroxysmal atrial tachycardia. So sometimes it can be kind of a harbinger of things to come. But for the most part, figure out what the problem is and fix that. Common ectopy. Atrial fibrillation, I will test you on atrial fibrillation. I think it's important that no matter where you work or whatever, you're going to be able to identify this. So with atrial fibrillation, what's happening is that we talked about this earlier, there is a chaotic electrical storm. There's all this chaotic asynchronous electrical activity going on in the atria, and it's an electrical storm, and so electrical impulses are being fired at a very rapid rate, and like I say, we can't count them, but that rate is typically more than 300 times a minute, 300-400 times a minute. Now, those impulses are going to hit the AV node, but the AV node is going to hang on to most of them and only allow some of the impulses to pass through. And so, fortunately for us, the ventricular response is much slower. So the atria can quiver. and we still get, volume in the ventricles because of pressure gradients, and I'll be explaining that as part of the class stuff. So we're still going to get some cardiac output, but it's important with atrial fibrillation that we pay close attention to the rate. Because the faster the rate is on this, the faster our ventricular response, the less time we have to fill the ventricles, and that'll really impact cardiac output. Now, in terms of identifying this as a rhythm strip, it's easy. There's really only a couple things you need to look at. So let's go through it. Rhythm, regular, irregular, and you can see it's irregular. I mean, you don't even need to take some paper and mark that to see that you've got an irregular rhythm. Rate, we're certainly going to calculate that. So I've got a mark here, here, and here. So between our 6-second strip, I'm going to count 1, 2, 3, 4, 5, 6 complexes. So on this strip, my rate is in the 60s. Then I'm going to look for P waves. And that's really what defines AFib. AFib is irregular, and there are no discernible P waves. And when you look at this strip, you see a bunch of bumps, and it's easy to say, wait a minute, that looks like a P wave. But remember from the previous strips, P waves are consistent. This little bump here isn't a P wave. All of this stuff is just the fibrillatory baseline. So irregular and no P waves, it's pretty much got to be AFib. Now, because there's no P wave, we can't do a PR interval. And ratio, you don't have a P wave for every QRS. Now, we look at the QRS complexes, and we want to make sure they look about the same. Now, keep in mind the quivering of the atria, the fibrillating atria does not stop. Even when we get ventricular contraction. So sometimes you can see maybe some little bit of differences in the QRSs. This one's pretty good, but don't worry about that. It's because of that fibrillatory baseline. I can still measure the QRS, so I can still, on the V-lead, I can measure from the beginning. Now, by the way, V-leads, QRSs should be downward like this. That's the way they're supposed to look, so don't worry about trying to flip the strip. So this is my R wave and my S wave. Okay, so I'm going to measure from here to here, and this is a little bit wider. So my QRS from there to there is a little over 0.12. It looks like it's maybe a 0.13 or 0.14. So I have a little bit of a wider QRS. If I measure the QRS here, this one's maybe a little easier to see. Look at this one, nice and crisp. So from here to here, you'll notice that I'm at 3.5, almost 4 baby boxes, so about 0.14. So I do have a lengthened QRS, and remember that QRS, measurement tells me how long it's taking the impulse to go through the ventricles, and so something's slowing things down. This patient probably has some cardiomyopathy or something going on. T waves. It can be hard to see T waves because of the fibrillatory baseline. You'll notice that I don't really see much of anything here. Now I see a tiny little bit of an inverted T wave here. It's kind of, I got a little inverted T wave here, but it's kind of obliterated by the fibrillatory baseline there. I can see a T wave here. Okay, so that one's pretty easy to see. So when you're looking to do your QT interval, find the crispest one. The one that's most, I can see the easiest. And so I could do a QT interval on this one. So from the beginning of the QRS to the end of the T wave. Okay, so beginning of QRS to the end of the T wave, and I'm eyeballing it. Because I can't take my paper up on the screen, and it looks like it's a little less than 2 big boxes, so it's a little less than 0.40 seconds. All right, so setting. So once again, when we look at atrial fibrillation, this tends to be people that have problems that stretch out the atria. So valvular issues, COPD, heart failure, hypertension, heart attack, cardiomyopathy, also hyperthyroidism. Patients coming into the ED with a new onset atrial fibrillation, they'll oftentimes check thyroid levels to see if that was the cause of the new onset AFib. Digitoxicity, you'll see pops up again. Digitoxicity causes any dysrhythmia known to man. And advanced age is a risk factor. The older we get, the more likely that we'll develop atrial fibrillation, and alcohol is also a risk factor, overconsumption of alcohol. So what do we do first? What do we always do first? Assess your patient. So you need to go ahead and get vital signs. You need to check skin color, temperature, capillary refill, level of consciousness. You need to listen to heart and lungs. So get that assessment, maintain airway, breathing, and circulation. So the first thing we typically look at, whether this is a new onset or somebody that's had atrial fibrillation forever, is rate. We know that the faster the rate, the shorter the diastolic filling time. And one of the problems with atrial fibrillation is because the atria are just quivering and we never get atrial contraction, we lose some of the volume that we're going to get into the ventricles. Atrial contraction happens at the end of diastole, and it gives us about 15% of the volume that we're going to get in the ventricle. Most of the volume in the ventricle, most of ventricular filling during diastole is just a pressure gradient, and so most of it is passive. The atrial contraction happens at the end of diastole, and that gives us that little bit of extra volume. With atrial fibrillation, we don't have that. Now, we still get some volume in the ventricle, but we need time. We need diastole, so we have to pay attention to rate. If the rate picks up and I have less time to fill the ventricles, my heart rate will continue to increase in order to compensate for that, and that just makes things worse. So look at rate, and you'll see in your page, if you're looking at your packet, it says we need to control the ventricular response, so we need to slow the heart rate. We don't need to slow this rate, by the way. It's pretty good, but if the rate was rapid, we would want to slow. And so if the patient's stable, we can give medications. And so the medications that are commonly used are beta blockers or calcium channel blockers, and we tend to go with calcium channel blockers that are non-PENS. And so that includes verapamil and diltiazem. Amiodarone is an antidysrhythmic that can also slow conduction and hopefully convert the patient into a sinus rhythm. If the patient is unstable, then we need some electrical therapy to reset, and that's going to be a synchronized cardioversion that we'll be talking about in the class portion of things. So just tuck that in the back of your head, and then we'll try to maintain that sinus rhythm if we can get it. Now, the other problem of atrial fibrillation is when atria are quivering, we have stasis of blood in that atrial chamber, especially in the atrial appendage. And so anytime you have stasis of blood, you have blood that's not moving, clot can form. And if we have a clot form in the atria and the patient happens to get an atrial contraction, or the clot manages to work its way into the ventricle, it's going to go flying. If it's coming from the right side of the heart, it's going to go to the lungs in the form of a PE. If it's coming from the left side of the heart, chances are good it's going to go flying, and the first branch off the aorta is the carotid, and so it's going to go to the brain and cause an embolic stroke. In fact, we know that atrial fibrillation is the #1 cause of embolic stroke. And so for patients with atrial fibrillation where we're not able to convert them into a sinus rhythm, they may require anticoagulation. Not all patients with AFib need anticoagulation. A healthcare provider will look at a patient's risk factors and make a determination. So we'll be talking more about this in class, but do keep that in mind. Look at rate first, whether it's new or old AFib, persistent AFib, and then we consider whether the patient should be, whether we want to attempt to convert them into a sinus rhythm, what are the risks of clot. Atrial flutter I put in here real quick. This is not a rhythm that I'm going to be testing you on, but it's interesting. And it's kind of cool looking, and so just really quickly, with this, it's atrial flutter and atrial fibrillation. When we look at the setting for these, the kinds of patients that develop this type of dysrhythmia, it's the same sorts of patients. In fact, some patients will have what we call fib flutter, and that they'll have little episodes of atrial fibrillation, and then they'll go into flutter, and then they'll go back into AFib. But A-flutter is just a little bit differently. Now, one of the things you notice when you look at this strip that kind of stands out is, do you see the baseline where we have what are called sawtooth flutter waves? It's kind of like these V formations along the baseline. And that actually is, there's an irritable area, an ectopic pacemaker site in the atria that is firing off an impulse at a very rapid rate. And that impulse is just kind of flying around the atria. And it's actually causing some atrial contraction, but the atrial contraction is so fast. On this strip, it's about 270 times a minute, that we really don't move a lot of atrial volume. And remember that the atria can tolerate contractions at 270 a minute, but not the ventricle. We would have no ventricular filling time and pretty quickly a dead patient. So what does our heart do? The AV node protects us from excessively high atrial rates, and so only some of those, only some of that conduction or that electrical activity from the atria gets through. Now, when you look at the rhythm, regular versus irregular, you'll notice that the first part of the strip, it's darn regular. But then what happens, you see kind of a long pause and a lot of flutter waves. So when I look at this strip, it's actually irregular. You can't ignore the fact that we do have this longer stretch that makes it irregular. Rate, so what have I got on the rate? Let's find our, I'm sticking my finger on it and you can't see it. So here's a grid. Wait a minute. No, I don't know if that's a grid or not. Well, 3 seconds, 3 seconds. Ooh, I don't know if I've got 6 seconds here. Let's see. Huh. Okay, I'm going to approximate the rate for you again. This may be, I can't tell. I could count it out, but I'm going to approximate a rate for you. 150, 170. Rate, once again, on here is probably about 70 or so. P waves. I don't see P waves. I see my sawtooth flutter waves. Okay. So I can't do a PR interval. I'm going to look at my QRS complex, and remember the fluttering of the atria doesn't stop, that little atrial contraction. So when you look at the QRSs, once again, you may notice that some of them look a tiny little bit different. These are our flutter waves. So when you look, this is a flutter wave, a flutter wave, a flutter wave. The flutter waves don't stop. So I still got a flutter wave, a flutter wave, a flutter wave, a flutter wave, and it continues, okay? And so that's why you'll see some differences a little bit with the QRSs and even the, my ST segment depression and my ST segment and my T wave. I can't really tell where the ST segment is. So I'm going to find the cleanest one. I have no P waves, I can't do a PR interval. I could probably do a QT. There we go. Look at this one. Let's see. Maybe this one is probably the cleanest one. Beginning of the QRS to the end. So it looks like my QRS from here to here is maybe just a little bit over 2 baby boxes. So a little bit over 0.08, maybe 0.10. So that looks pretty good. T wave. I can't really tell. I mean, this may be the T wave. It's probably the T wave, but the flutter waves I know don't stop, and so flutter waves are probably obscuring some of my T waves. So I can't look at this and say much about the T waves. I might be able to guesstimate a QT interval here, but it's pretty hard to do. And you'll notice you can't see T waves at all. All you see are flutter waves on the V lead. So can't really do much with that. Wait a minute, maybe I could do a QT interval out of this one. Let's see, or maybe this one. Beginning of the QRS, possibly the end of the T wave. Beginning of the QRS, end of T wave. Okay. All right, setting, like I said, same things that caused the atrial fibrillation can cause flutter. So same idea with atrial fibrillation. We've got to control the ventricular rate. We're going to look at maybe beta blockers, calcium channel blockers to slow the ventricular rate down a little bit. We need to assess to determine whether the patient needs anticoagulation and or cardioversion, electrical therapy to try to get them into a sinus rhythm. All right, the last strip I'm going to do in this part of the packet is SVT, or supraventricular tachycardia. I've been kind of talking about atrial dysrhythmias. The next portion of the packet is going to go into ventricular dysrhythmias. So when you look at this strip, supraventricular tachycardia, one of the things you notice is that it's really fast. So that's like tachycardia on steroids. So SVT occurs typically when, this isn't the SA node anymore, folks. This is an irritable area in the atria that took over from the SA node and is firing at a very rapid rate. One of the things we know when we're looking at an adult patient is as an adult, your SA node is rarely going to pace you any faster than 150 to 160 beats a minute. So when we see an adult with a tachycardia like this, and it's a narrow complex tachycardia, when we see an adult like this with that type of tachycardia, we call this supraventricular tachycardia, meaning it's not ventricular. Ventricular tachycardia has a wide QRS complex, but it can't be the SA node because the SA node, the SA node just isn't going to pace an adult that fast. So somewhere above the ventricle, something took over and is pacing the heart. So let's look at it. Regular, irregular on the rhythm. Beat to beat, take your paper and march it all out. And I could actually you can see that my rhythm is regular all the way through. Great. So I've got here 3 seconds to here, so 6 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23. Ay caramba, that's really fast. So we've got a rate of about 230 beats a minute. How do you suppose your patient feels? Not so great, because the rate is fast, but I'm not filling the ventricles, so my cardiac output is in the tankers. Chances are good your patient is going to be very hypotensive and very unhappy. You still need to assess your patient. So rate is very fast. You'll notice that it's impossible to find a P wave. And that's the other thing we see is you really can't discern a P wave. So you can't do really a PR interval. QRS complex is narrow, and everything's kind of squished together, but the QRS complex is less than 2 baby boxes, so it's less than 0.08. I don't really have a ratio on here because it's hard to tell. I probably, if I have a P wave, I got 1 P wave for every QRS. I mean, that could be what's here, but it's hard to tell. T wave is also going to be difficult to see. If there's a P wave on top of here, it's going to be hard to see. I can't tell whether this is ST segment depression. It looks likely, given the fact that the heart rate is so fast, that the patient's kind of ischemic from that. So, setting. Now, this can be a finding in healthy as well as diseased hearts. There are patients that have perfectly healthy hearts that will have episodes of supraventricular tachycardia that are idiopathic. We don't know why. There are some patients that have what are called accessory pathways that can create something like this. It can also be associated, though, with problems, things like caffeine, stimulants, alcohol, nicotine, anxiety, fatigue. It can be an electrolyte issue. We'll see this sometimes with patients that have COPD. Once again, digitoxicity shows up, hyperthyroidism, congenital heart disease. So what do we need to do? You got to assess your patient. Like I say, with a rate like this, they probably don't have a lot of cardiac output, and it's likely that blood pressure is very low. If they're conscious, they're not going to be feeling so great. You may have some changes in level of consciousness. So remember on SVT, the ACLS algorithm, if the patient is stable, the first thing you're going to do is have them do a vagal maneuver. You're going to ask them to cough or blow out, against something, a syringe or a straw or whatever, or bear down, whatever. We're going to try vagal maneuvers. If that doesn't work, then we're going to give adenosine. And remember, this is the weird med in that it's called a chemical cardioverter. It can make people feel not so good, and it has the extremely short half-life. And so if you're going to administer that, you've got to either hook up a Y port or a three-way stopcock and put both your flush and your med on there. Push that med in as fast as you possibly can, and I'm talking about maybe a second or two, and right away follow it with that flush. Flush will be more like 3 seconds because you're going to have more volume there. Now, warn your patient if their level of consciousness is appropriate, warn them that they might have some discomfort, but it's going to be very fast, okay? And I do like to have a monitor at the bedside when I'm administering adenosine. So the dose on the adenosine, 6 milligrams the first time. If it doesn't work or it doesn't get us as low as we want it to be, we'll give 12 milligrams the second time. If adenosine didn't work and they remain stable, then we could consider beta blockers or calcium channel blockers. But if this patient was unstable at any time or unstable to begin with, then the recommendation is a synchronized cardioversion to get them back into a sinus rhythm. All right, so that's the end of this particular section. This was atrial dysrhythmias, and so you can take a little break and then go on to the third section, and that's going to be our ventricular dysrhythmia.